These are the author's credits. We all are aware that the hypertension is a major risk factor for the major CV events, whether it's an MI, sudden cardiac death, or stroke. And the BP variability is known to all of us. That BP variability on daily basis, there is a normal dipping of 20% at night. And we see here the normal dipper with a high blood pressure also variable. And there is definitely non-dippers who are responsible with a high degree of morbidity and mortality in diabetics. Extreme dipper also have a high morbidity. And we also see the non-dippers with age-related and have target organ damage, have a significant degree of non-dipper. White coat hypertension is also very well known to you. What is the available evidence before this study? Why this study was done? Maple study, which was done in 2010, and Hygia chronotherapy study done in 2020. The number of patients in MAPEC study were 2,000, while in Hygia chronotherapy were 19,084. And the message was very clear from this study that there was a substantial reduction in the major CV events, vascular death, MI, or stroke. It was much more significant in evening dosing as compared to morning dosing. Both the studies, methods, and plausibility was questioned by experts. So that was the main reason that the time study was planned. And this time study is large, pragmatic, prospective, open-label, blind endpoints, randomized, decentralized, superiority trial conducted in UK, comparing CV outcomes in adult hypertensives, evening versus morning dosing in hypertensives. This is very clear from the MAPEC study that the event-free survival was better at the bedtime in 2010. And we see here in 2020, Hygia chronotherapy study also documented the same, that the major CV events were reduced with the evening dose treatment as compared to morning dosing. Now, what is the aim of time study? The aim is to evaluate CV outcome in adult hypertensives on evening versus morning dosing of antihypertensive, and to compare the major CV events in the form of vascular death, MI, stroke, heart failure, or coronary revascularization. What was the inclusion criteria? UK residents aged at least 18 years with diagnosis of hypertension and taking at least one antihypertension medication on daily basis. Very clear, we can see here the baseline demographics were almost similar in both the groups pertaining to age, sex, BMI, current smoking, diabetes, impaired renal function, prior CVD, and BP. And the number of patients are already mentioned here. The time study protocol was like this. All patients were screened. They gave their consent. Randomization was done. Follow-up was performed through an online study portal and by email. Consenting participations were randomized 1:1 on antihypertensive therapy. Evening dosing was 8 p.m. to midnight, and morning dosing for 6 a.m. to 10 a.m. And we can see here, these are the characteristics of the time study. It was done from 2011 to 2018, screened with 24,000 patients. Randomization was done for 21,000 patients. Group 1 and Group 2, the number were almost identical. Mean age was 65, and the ratio of male and female was 57:42. Ethnicity was not reported. Previous CVD were 13%, and the follow-up was 5.2 years. This was the study portal in brief. You can just have a look at it. And this was the outcome, primary outcome in the form of vascular death, hospitalization for non-fatal MI and non-fatal stroke, analyzed as the time to the first event, while the secondary outcome was vascular death, hospitalization for non-fatal MI and non-fatal stroke, all-cause mortality, dosing schedule, reference to diuretics only, and reported events were also noted, like falls, fractures, or other symptoms. This was the endpoint capture and adjudication chart, which is mentioned here. This was the outcome from evening dosing versus morning dosing. We can see here, there was hardly any significant difference between two groups. Evening grouping and morning, we can see here 3.4% and 3.7%. Similarly, secondary endpoints also, there was hardly any difference of significance in evening doses versus morning dosing. This is just to show the details of the outcome data from group 1 to group 2, evening doses versus morning doses. There was no significant difference in the primary endpoints and secondary endpoints. We can see here in the graphic record, red in morning dose and blue is evening dose, no significant difference on the long-term follow-up of more than 5 years. Secondary endpoints, non-fatal stroke, non-fatal MI, CV death, CV all-cause mortality, and CHF hospitalization and death were also not significant different between morning and evening dosing. This is just to compare the systolic blood pressure by home blood pressure monitoring in both the groups. There was no difference. In evening and morning dosing, there was no difference at all. And this is the outcome between the group 1 and group 2. Non-adherence was significant in the evening dosing as compared to the morning dosing. We can see here, there is a significant difference. Well, the withdrawals were almost equal. Fractures and falls, also there was no difference in the evening dosing and morning dosing. And we can see here the primary and secondary outcomes follow up for 5.2 years. There was no difference in the outcome, and all-cause mortality was also not different. Now, what is the strength of this study? As compared to the MAPEX study and the other study which I mentioned, the study is pragmatic, and we can see here it is decentralized, long-term follow-up, good participation retention, record linkages, and educated hard points. They all were very, very meticulously reported. The weakness of the study is also known to us. Participants were self-selected. So some of them were interested in health, some of them were not interested in health. But IT literates were more participants, and low adjudicated event rates were also there. Non-compliance with the randomized dosing were some of the limitations or the weakness of the study. And you can see here, the ED of blood pressure medication not better than morning dose is very, very clear. Well documented by ESC, in the Congress, in event, journals, guidelines, in education and the research in 21,000 patients who were followed up for 5 years. Take BP lowering medicines morning or evening has no outcome significance. That was a very clear-cut conclusion. To conclude, ladies and gentlemen, evening dosing or morning dosing of antihypertensive medication did not improve the primary endpoint of hospitalization for non-fatal MI, stroke, or vascular death. Taking medications in the evening was not harmful. Patient can be advised antihypertensive medication morning or evening as convenient from the compliance and adherence point of view. Evening dose or morning dose makes no difference so far as the cardiovascular outcome is concerned. Thank you very much for your kind attention.